along with my fellow members of the GPRI, we're pleased to be publicly sharing our energy, enthusiasm, and vitality in pursuit of the best Rhode Island that we know is possible. In the next 2 hours, we hope to hear your thoughts on a state government which citizens can know is committed to people, peace, and environment. Our state is known as the Ocean State, and we are proud of our state's beautiful natural bounty. Sounds kind of corny, but it's true. That natural heritage is at risk from urban sprawl, climate change, sea level rise, and a political climate that makes our resources available to the highest bidder. The Greens defend the environment strenuously because people's lives and livelihoods depend upon it. And we gratefully, our great history goes back to Roger Williams and beyond, and we gratefully acknowledge our indebtedness to the original caretakers of the land that we now know as Rhode Island, the Narragansett, the Niantic, Wampanoag, and other First Nations people of this area. As a Green Party of Rhode Island, we pledge to always advance the interests of people who live here in Rhode Island. The Green Party of the United States is a federation of state Green parties similarly committed to environmentalism, nonviolence, social justice, and grassroots organizing. As part of the Green Party of the U.S., we pledge to advance the interests of people who live in this state, this country, and on this planet. Later in this meeting, you will have questions and answers with open discussion, and we invite you to participate vigorously. Let me draw your attention to the posters on display, this one in particular. These 10 key values are the foundations we as Greens proceed from. And the first one is grassroots democracy.
Social justice and equal opportunity.
Ecological wisdom.
Okay.
Nonviolence.
Decentralization.
Okay.
Community-based economics.
Feminism and gender equity.
Thank you.
Respect for diversity.
Personal and global responsibility.
Future focus and sustainability.
Thank you. Yes, those are our 10 key values. When addressing issues involving our state, all of our policy positions are informed by those 10 key values. Our policy positions are never determined by who gave us how much money. We're renewing democracy without the support of any corporate donors. In short, we don't take corporate money. So welcome. Our speaker today was to be Dr. Michael Fine, who's a subject matter expert in the area of health. Greens believe that healthcare is a right, not a privilege, and we recognize that our own health is also tied to the health of our communities and the environment. The Green Party supports single-payer universal health care and preventative care for all. Dr. Michael Fine can't be here today, but due to a death in his family, but let me tell you a little bit about him. He has an extensive resume, which includes serving as director of the Rhode Island Department of Health. He's been recognized at a national level for his research on healthcare delivery systems and was managing director of Health Access RI, the nation's first statewide organization making prepaid reduced fee primary care available to people without employee-sponsored health insurance. And he has written a book on the subject, The Nature of Health. Tonight we have with us, though, Lynn Blanchette, an Associate Dean of the School of Nursing at Rhode Island College, who was asked by Dr. Fine to speak in his place and has graciously accepted that invitation. She is also the Vice President of the Scituate Health Alliance, which is the first neighborhood health station in the state. Yes.
Well, in the U.S. probably too.
And probably, as I was wondering, in the U.S. as well. So let me welcome you.
Thank you.
Please.
Thank you.
Come on up.
Thank you for allowing me to substitute for Michael Fine. I will say off the bat that I'm a poor substitute for him in most things, but the neighborhood health station concept is certainly a vision that I have shared with Michael almost from its inception. He and I sort of come at this model from two separate places. I'll start at the beginning, and I would just want to say that I spent about 10 minutes upstairs because this is the library of my childhood. point, yes, at some point, I read every book in the children's library that the children's librarian would let me read. She would let me go past, the gate. And in 5th grade, I guess she thought I really shouldn't be reading anywhere past the adult books. So, but that's okay. I still enjoyed it, and it's a good memory to come and spend some time here today. I am a nurse. I graduated from Rhode Island College a long time ago and went immediately into the care of people who were living in their homes. So I spent most of my 35-year career now doing community-focused and healthcare. So I worked for several home care agencies in the state. I've worked for a number of community-based organizations like Children's Friend and Service, working with families who were involved in DCYF care because of parental substance abuse. So I've got a history of working with folks who are struggling with addictions as well. I decided about 15 years ago that what I wanted to do next was to teach the sort of next generations of nurses who were coming up so that I could impart the concepts that you are advocating in your values, that health comes from the place where you live, work, play, and learn, and not necessarily from a practice and setting in a physician's office or a hospital or those other sorts of providers. And I think nurses have for a long time also valued that just as a professional value. So I lived in Scituate with Michael, where he still resides. And that's sort of how we ended up having Scituate be sort of a testing place for our concept. We recognized that there were a lot of people who lived in Scituate who did not have insurance that covered them to have access to primary health care. Michael spent a lot of time researching how much does it actually cost to have a primary care visit, the one-on-one sort of visit with your provider, nurse practitioner, physician assistant, in order to maintain your health status, do early symptom diagnosis screenings, and then, hopefully doing some prevention. And his belief that a lot of your individual health can come from that sort of relationship. Came up with a dollar amount, and that's what he was doing in Health Access RI. So he was having folks prepay to be members of his primary care practice. So if you had a health insurance that didn't pay for you to go and get your annual physical or sick visit, you could pay a sliding scale based on your income every month, somewhere between $25 and $35 a month, to the practice. And for that, you could call up on the day you were sick and be seen on the day you were sick. His primary care practice had extended hours into the evening and on Saturdays because, let's face it, folks, people get sick after work and on weekends. Like, people can't really afford to take days out of work when they're sick. So, but they responded really quickly, so they avoided the emergency rooms, the urgent cares, all of that kind of stuff by really managing the care of the people who were in his primary care practice. And he saw an opportunity to do that with the community that we lived in Scituate, starting with the municipal employees, some of whom only worked part-time. The town was paying for them to have full-time Blue Cross and other products like that, and the cost, was going really very high. And so it really wasn't practical for this small community of about 10,000 people, despite the fact that it's, sort of suburban and relatively middle class. They don't have lots and lots of, money to throw around frivolously paying for high-cost insurance programs. So he was thinking there was a better way to manage it, that if we could just somehow get everyone primary health care in the individual relationship, we could maybe use this health savings account project to sort of put aside the money, for high deductibles and things, and then buy a high deductible insurance plan, which is a lot of the model that the Affordable Care Act ended up being focused on. The difference is that they legislated that primary care be and that came into the Health Source project. So they just mandated that primary care had to be insurance marketplace. So we did a lot of research, and we tried really hard to get somebody to write an application on an annual basis for which we gave them a voucher for medical care and dental care. We didn't have behavioral health coverage at the time because there really isn't good primary care for behavioral health. It should, sort of a single visit every year and some screenings isn't really, consistent with the model of what most people need in behavioral health. So we talked about it, but it just wasn't going to fit at this point. And so the first year that we rolled it out, we had over 250 people in town who had no coverage through their insurance plan to get access to primary care. So we gave out about 250 vouchers for medical and dental care, Dental care was a lot of people, older adults. You get on Medicare, you have no dental care. No coverage for dental care if Medicare is your only insurance. So you hit 65 and you better go into it with your teeth in good shape or have them all pulled out when you're 64 and get a good set of dentures. That might last you for the rest of your life because you got no dental coverage after that. So over time, this has evolved into this notion that we should be combining primary care with population-focused health care. So the idea that where people live and work and play and go to school really does impact their health. And how could we bring the information that was generated inside of a primary care practice? How could we bring all that data about what are people struggling with their own personal health? What factors in the environment are making it harder, presenting barriers? What are the facilitators in the community that really might help people gain the ultimate health for themselves and for their family, for their neighbors? So he partnered with a group of people in town. I was one of them as a nurse. We partnered with an ambulance company, so a group of first responders who had that sort of background and training, and a former town council member, so we sort of had the political, sort of will from somebody who understood how that part of the community worked. And we created the Scituate Health Alliance, with the notion being that we would not only provide access to primary health care, but we really would take a look at what were the population needs of the community. So we do things like run a seasonal flu clinic, and free of charge. We do it all volunteers. We've gotten some funding from the Rotary Club and some other people to pay for our supplies, but everyone in Scituate has access to a free flu vaccine every year because we've set up that program. So that's sort of a little tiny thing, but still, we can really brag about the high rate of influenza coverage in our community for adults who aren't traditionally covered for that. So we've partnered with the senior center, with the schools, with the libraries to communicate health education information. Our Scituate Prevention Partnership is a really active member of our group, so we support them to do their prevention work. So whenever we can, we partner around events and things. This past weekend, so eventually we convinced Well One Health Center, which is a federally qualified health center that has offices in Pasco, Foster, and North Kingstown, to build another satellite site in Scituate. Because we had no primary care provider who had a practice in Scituate. Everyone in town went out of town for all of their medical care. There was no healthcare providers in town. I shouldn't say that. There's a nurse practitioner, a nurse midwife, who has a small practice in the Hope end of the community. But she certainly doesn't have the capacity at any point to care for the entire community. She has another full-time practice, in addition to this. So it wasn't her goal to become our provider. So they moved in, they built a new what we are calling the Neighborhood Health Station in town. So it's the Well One, all of the services, dental services, behavioral health services, medical services, at a federally qualified health center, so people can come in there on a sliding scale or use their private insurance or privately pay, however they choose, to access those services. And they built us a really nice community room with the opportunity to do educational programs, individual counseling, screening, carry out all of our sort of population-focused activities in that same building. So Neighborhood Health Station was born last October. And I have the advantage of having 8 students every semester who are studying community and public health nursing, and so they sort of truck out to Scituate with me and take on this model as a great way to learn about where health comes from and how to really focus on the social determinants of health and the connection between the individuals and their bodies and their state of wellness to the entire community and what resources it has to offer. So I know you've probably heard, but Michael's dream is to open the second one in the state of Rhode Island in Central Falls. So he's taking his medical director practice, his role in the mayor's office as the medical director, and really doing a very population-focused project in Central Falls as well. When they get their new site, it will be called the Central Falls Neighborhood Health Station as well. Okay, so that's my speech I give to the students every semester and to funders that I've asked for money from before. So can I answer some questions? What did I say that intrigued you? Or
Your insistence on the word station versus center, I know there's something behind that. Can you explain?
It's interesting because it's Michael's attempt to sort of stay away from words that are used in other healthcare settings, right? So we're not a health center because that's sort of what other already established organizations are calling themselves. it really was an idea to step away from the traditional way that healthcare is delivered to people and really help people think about a whole new model for that, so a neighborhood health station. The other thing is, his theory is that if we can get 90% of the people in our community to come to the health station to get 90% of the care that they need, then we would really truly have probably the healthiest community in the, and pretty much anywhere. So if we could really get what everybody needs, what everybody is looking for, and what would help everybody sort of all under one roof, kind of, even though we don't think all the services come from a roof. But the planning, the collaboration, the recognition of needs and barriers and all those kinds of things. So, yeah. Yep.
Does this include prenatal care? Does this include prenatal care?
Does the health station, so the Well One offers that care, but not in Situate yet. We don't have enough. We hit in the last 15 years, we hit an all-time high in 2016. We had 90 babies born in town. Yeah, so for the 16 years that I've been monitoring the birth rate, we've crossed 90. We were at 88, 89, 87, but we hadn't crossed 90 yet. But 2016 gave us 90. So while it's something that we need, and we have all kinds of interesting information about the babies and the mothers who are born in Situate, the 80 or so babies that were born in 2014 went to 50 different medical practices, providers. Some of them are in the same practice, but think about the impact of that. If there's something going on with moms and babies in Situate, we don't know about it because nobody's bringing all the information together to say, there's a trend in Situate, and I bet we could figure out what's causing it or what to do about it. But because all that information isn't coming into one central location in any way, except that I nag the health department every year to give me the data that they own, public data, and I still have to nag them for it every year.
So pregnant women were going to various OBGYN.
Yes, and midwives and
in Cranston, Warwick,
all over.
Providence, wherever.
With no rhyme or reason.
They don't. Now, what about electronic records? How does that factor into it?
Well, it depends on which practice the provider is connected to, whether or not their records can talk to primary care
What about the
providers.
station? Does the station involve itself with electronic records?
No, because
Isn't that
we don't
something-
deliver health care to, so the Well One Health Center does. The clinic itself does, because they are a federally qualified health center, so they are subject to all of those
Right.
rules and laws about documentation and data collection and all of that kind of stuff. So we will, in the neighborhood health station, use their aggregated data. We can ask them, for example, we can ask them about the income levels or race or ethnicity. We can ask them about cigarettes smoking. We can ask them about seatbelt use. So they can pull out the data from their electronic health record and tell us if we have a good rate of seatbelt use or a poor rate of seatbelt use among people who live in Situate. So that's how the partnership's really gonna work. People who come in there. I started to say last week we did a health education project at the Situate Lions Club Scholarship Breakfast, because that's a place that brings a lot of people in town out into a public setting. And so we've learned a couple of things. One is that we have a really high rate of Lyme disease for folks in Situate, which makes sense. It's really rural, lots of stone walls. The deer like the reservoir, the little rodents like the reservoir. So we have a really high rate. The provider inside the Well One Health Center said to me, I can't believe how many people I'm screening for Lyme disease. It's 5 times what I was doing in my practice in Cranston. So he's taken himself off to become an expert at treating Lyme, to try to figure out the clinical aspects of it, and then he came to us and said, we need to do more health education, we need to think about prevention, we need to help people in the community understand what puts them at risk for developing Lyme disease. So we did a whole series of educational seminars at the libraries, at the scholarship breakfast. We passed out tick tubes. They're permethrin-soaked cotton balls stuffed inside of a water-resistant tube. And the idea is that the mice and other small rodents take the cotton back to their bedding, to their nests for bedding, and the permethrin kills the ticks. So if we can cut back on the tick population, we'll cut back on the number of people who are infected with diseases that come from ticks.
Just to try something, have you considered birdhouses for small owls that kind of eat rodents? That would lower the
That's
reservoir.
absolutely one of the other options. It's so interesting what people's responses were to this, though. They were worried that somehow the tick tubes were actually going to entice rodents to come to their yards to get the cotton balls. well, you know, people really, mice live in your yard. It's like, that's just already the reality of the community. But yeah, I would love to.
That would be
but
cheap.
I would absolutely love to hear like some other, as many alternatives as we can offer. But this is the difference between you going to the doctor and learning that you have Lyme disease,
Yeah.
as opposed to us sort of way backing up upstream and saying what puts people at risk for developing Lyme disease and how can we stop it from coming to the individuals who have Lyme disease. So, and again, in an environmentally sound way as much as we can, because we do live near the reservoir too, and we need to be careful about impacting the water supply.
When you say that Well One is a federally qualified health center,
Yes.
does that mean it is in any way subsidized or available for federal funding?
It's completely subsidized. Yes, the federal government, these federally qualified health centers started in the 70s. So there's a whole series of them in Providence. Thunder Mist is the biggest sort of chain. People probably recognize that name. But they are federally qualified health centers, so there's a process by which you get verified to be able to qualify as a federally qualified health center. There has to be a minimum number of people in an income level, and yeah.
So the people who come there to seek health care,
Yes.
are they charged on a very sliding scale?
So the nice thing about a federally qualified health center is that it's for everyone. So if you have no insurance and very low income, they will charge you on a sliding scale that may result in no fee. Or if you have the very best Blue Cross has to offer, you can still get your health care there. And so we're hoping really to sort of, that's the other thing. There's a little bit of a stigma attached to federally qualified health centers, right? Most people think, oh, that's where the poor people go and not where the people who have health insurance go. And really some of the best care that's being delivered in healthcare today is being delivered in these health centers because they understand the social determinants of health, the impact on people's health, where they live, where they play, where they work, all of that kind of stuff. So they've long thought about access to other kinds of supportive resources for people. So
even if you came in, let's say you had Lyme disease,
Yes.
you were diagnosed with Lyme
Yeah.
disease, it would be treated for free.
but potentially based on your income.
Oh.
Yes.
Health insurance you have.
If you have health insurance, they're going to bill your health insurance. Yeah. Yeah.
The Promethean, that doesn't hurt rodents?
No. That's the best evidence we have right now. I wouldn't doubt that over time, constant exposure, perhaps it has some long-term effect, dose related to how much permethrin they're exposed to. But little tiny bits of cotton ball is enough to kill a bunch of ticks and not hurt the mice. Yes, or the other rodents. Did you have a question?
I was curious, you might not have had the chance to really enact this, but chronic healthcare issues, diabetes or neurological or things of that nature that
Yep.
is based around wellness with prescription refills. How does Dr. Fine kind of envision that sort of thing interplaying, particularly like in urban settings perhaps?
So the management of chronic illness, you mean? Yeah. So I think what Dr. Fine envisions is our communities that are supportive of people who are living with chronic illnesses.
Right.
And degenerative diseases and, all the whole variety of things. So that the health station would be the driver of policies that thought about things like access to buildings and sidewalks improvements that allowed, people to use wheelchairs or other handicap devices. And so the whole big picture. But again, it would be community specific. So, and it would really depend on, does that community need those kinds of resources? So we can probably assume that they're in this institute where there are 10,000 people, that there's somebody who's living with a chronic illness, there's somebody who's living with a degenerative neuromuscular disorder, there's probably someone who has cancer, someone who has heart disease, but we want to know, we want to have such an intimate relationship with those 10,000 people that we know not only maybe right where they are and where they live and what modifications they might need to their home or for school or for access to transportation, access to support resources, home health aides, medical assistance, those kinds of things. That's the idea, that we would know. When I've done presentations on the health station idea before, what I've often used is pregnancy as an example, right? So most people think pregnancy is a pretty healthy state to be in, right? And in a relationship with a healthcare provider, so your OBGYN or your midwife, you have a very specific relationship with that provider around your pregnancy, right? There's a whole series of protocols about measurements and weights and blood tests and screenings and all of those kinds of things. But at the population level, we're worried about pregnancy for a whole other set of things, right? What we might be worried about at the population level is prevention of pregnancy, right? Or preparation for pregnancy. So there's a whole lot of stuff we know about if you're thinking you want to become pregnant. Things you might want to do to get your body into the best state to support a successful folic acid and those kinds of things. So the lens that we look at the topic with is sort of very different. I mean, if I'm the town nurse in Situate, which is what we're talking about, the person who will sort of manage all of this is the nurse who's on the ground managing this, calling that nurse the town nurse. That nurse will have to be skilled at understanding both the population and the individual focus for those kinds of topics, right? So that's why we monitor things like how many babies do we have every year? How many of them are firstborns? What's the ages of the mothers who are giving birth in Situate? Do we have a concern in town about teen pregnancies or older moms who are getting pregnant? We have lead in our community. We don't fluoridate the well water. Did you know that?
Well, the well water would be fluoride.
It might be.
It could have.
It might be. So some wells have too much fluoride in them. Some wells have no fluoride in them. But the assumption is that everyone in Rhode Island has access to fluoridation as a public health intervention. We all have healthy teeth because we fluoridate the water. But if you have a well, unless you're monitoring that well, you have no way to know if your children are getting fluoride. So those are the kinds of things that a population-focused organization would be looking at, right? We'd want to ask those questions. When I had babies, I lived in Situate, my pediatrician took 4 months to ask me if I was drinking from a well. I knew and was already managing it, but it took, because I drove to the east side of Providence to get my care. And so the pediatrician wasn't thinking at all, oh, this is a person who traveled here from Situate, just thinking this is the person who traveled here with a newborn baby. But if we deliver that care in Situate, providers who are focused on the community around us, and I'm just using Situate at whatever community we were talking about, this is the idea of how we would do a better job. Do you have?
Yeah, is there any way to track the progress, right? So it sounds like the Central Falls project is underway, it's on track and everything like that. Is there a website that Dr. Fine's upkeeping or anything like that that we can go to and see where we can help out, possibly?
There's somebody behind you who might actually answer the questions about Central Falls better than me.
Okay.
But it is our intention in Situate. So we've been tracking some things, I know Dr. Fine is tracking, things like they've been doing a project to monitor the use of first responders for people living in Central Falls. Like they took the top 20 or 25 people who had used the most, ambulance runs or ambulance calls over the last year. Big expense for a community, right? People who call 911, because the laws in Rhode Island said if someone calls 911, you have to transport. You have to pick them up, put them in the ambulance, and drive them to a hospital emergency room, where they are then,
Is that a good law?
No, it's a bad law. It's a very bad law. A very, very bad law. Unless the individual refuses to be transported, and then they have to sign all these documents that say they don't.
So why the law?
Well, I think why the law was because there's a big gap between someone who thinks and initiates the 911 call themselves, and then entrusting the emergency responders to make the assessment about whether or not that person can safely remain at home.
So the liability?
But I'm sure partly, yeah.
I think, I forget how long that law's been in
Yeah.
existence, but long time.
Long time.
And I think at the time that was done, they didn't have the level of education
Right.
and expertise in the first
And we haven't
responders.
updated the legislation, although now there's a program going on right now. In fact, well, one is engaged in one called Community Paramedics, and Dr. Fine is engaged in it in Central Falls as well. So he's taken the first responders who are on the payroll, on call 24/7, they're waiting to be called and utilized, but given the current climate, the only thing they could be utilized for was picking someone up, stabilize. Of course, they do work when they get there. I mean, I want to belittle what they do. But making the decision in the community about whether or not that person could safely stay at home if we offered some follow-up, some phone calls, those kinds of things. Daily wellness checks. Those are things they're doing in Central Wells. So now instead of spending all of the city's money transporting someone, then that person's spending all of their health insurance money to get care they really didn't even need. Now we're using those same dollars, way fewer dollars, for the first responders to actually be in touch with that individual the next day. How are you today? How about I come by and check your blood pressure again? How about I come by and check your blood sugar again, or whatever the problem
I'm
is?
sure the emergency room is more that, there'll be less people coming through their door that really don't need to be.
Well, you know, that depends on which side of the emergency room thing you're on, right? Because if nobody shows up, you don't get paid. So, I think this is the bottom line, isn't it, right? There's like a set number of dollars to keep us healthy. And this idea that we parse it out to different organizations and different entities, as opposed to sort of saying, here's the whole thing. Where's the best place for us to allocate and spend these dollars? Is that the most efficient? Is it the most cost-effective? And does it result in what we wanted in the end? And that is healthy people in their healthy communities, right? So if we didn't have to worry about the emergency room might close down if we don't send enough people there, but rather we could say, okay, so what resources won't we need in the emergency room anymore, and where else can we use those people to offer some other level of care, some other kind of focused care, just like we're doing with the paramedics. Retraining, offering new skills, and then saying, you're a valuable part of this way we get healthy and stay healthy in Rhode Island, but we want you now to use your skills in this way instead of that. Two questions.
Okay.
Yeah, go ahead.
First of all, I'd like to say it sounds like you're doing some very good.
Oh, thank you.
Good work. But I have some concerns.
Well,
which,
yeah, I'd love to hear it, because it
uh,
really don't get
I
to
mean,
do much
and-
community forum. I usually stand here and tell people I know what I'm talking
Basically,
about.
my concerns can be the 3 C's, complexity,
Mhm.
cost, and choice.
Mhm.
Complexity because the treatment for one person and what affects one person
Mhm.
is not the same as what affects others.
Mhm.
And there's a lot of complexity in what are the environmental aspects. For example, fluoridation.
Sure.
There are problems
Oh,
with
absolutely.
fluoridation, and there's
Mhm.
concerns about fluoridation, and it's not a simple
Nope.
matter.
Eliminate.
Even vaccines,
Mhm.
we have a vaccine court which has put out billions of dollars
Sure.
to compensate people who've been injured.
Right.
And I think that may be a question of balancing, how many vaccines and which person has,
sure.
when, and all, it's just not that simple.
No. No.
And I don't.
I
my
apologize if
concern.
I made this sound simple. I'm trying to
Yeah. No.
simplify the
That's okay.
concepts,
I'm not
but I don't
criticizing
think anything.
anything
No.
that you said.
Yeah.
But I'm just saying that's something that needs to be addressed.
Uh-huh.
And one of the things there is choice.
Right.
Which,
Yeah.
what you choose to do.
Mhm.
It also has to do with what kind of care you choose.
Right.
And that, for me, and the cost, that combining with the cost,
Mhm.
there are 2 things that have struck me as things that are important to look into, at least. One of which is other countries.
Mhm.
We are number 1 on the planet in cost.
Mhm.
We're the most expensive healthcare system on the planet.
Right.
Healthcare
And number
effects,
36
healthcare
in our
results.
and healthy people.
round number 37 or so.
Yeah.
We're really not doing very good.
Yeah. Behind Turkey.
And many of most of the other developed countries, and
Yeah.
some of the less developed,
Mhm.
include alternative and natural therapies.
Oh, sure. And we would,
In
I would,
their
so here's
national
the thing, Liberty,
plans.
if the
Yeah.
community wants that, then they should get it
Yeah.
included.
So
There
that,
wouldn't be a sort of head or an individual
Yeah.
driving what decisions we make about what
Yeah.
people have access
Well,
to.
and-
The community members would.
and that relates completely to when the whole debate about the healthcare was going originally, but before the Obamacare was come in, the suggestion was made for consumer cooperatives for
Yes.
healthcare.
Yep.
And what you're talking about here, it sounds to me like it might be a perfect kind of setting or
That's our
a
hope.
situation for that.
Yep.
Where, and the thing about that is that the consumers themselves
Mhm.
in the cooperative make the decisions
Right.
about what health care they
Mhm.
want and need. They
Yep.
choose their providers.
Right. Yep.
And,
Yep.
it becomes a matter
And
of.
all of that could happen under a neighborhood health station.
So that's what
With
I
an
would
advisory
hope
council
for.
and a board and community members
Yeah.
and,
And my
meeting,
concern
town
about,
meetings.
my own concern about single payer is that it winds up that the federal government is deciding what healthcare I should get and what I shouldn't. And
Well,
in other countries,
that's a
they're
possibility,
open
but that's the way
to
it'll go, but-
various alternatives.
Yeah.
Our country is completely, let's face it, the pharmaceutical companies, the Telepath,
Lots of
they
people.
run the
Did you
show.
want to add something to her?
I
Yeah.
did. So I'm actually part of the EMS Office on Health Essential Calls. So we're in charge of the whole EMS.
You should introduce yourself.
Oh, Ashley Blair. I'm also an intern for Dr. Plan as well. So if you mentioned about alternatives in our alternative practices. So we have multidisciplinary teams in the neighborhood health station. So and it includes patients, doctors, it includes everyone under the sun. So what we want to do is we want to create neighborhood health stations everywhere, so we can have people like you come, tell your idea, have others support you, and build it. And
The first thing that's really needed, and this is a political thing,
Yeah.
I would love it if it was a scientific thing, we're trying to get naturopathic physicians licensed, because if they're not licensed, as they are in other states,
right.
We have in place right now to reimburse for the care and the work of the nurse who is going to run that clinic for us, that health station. So we've had to do fundraising and we've had to do grant writing, and we actually are we have a job posted right now for 20 hours a week to hire a town nurse. That's a model that I actually did my doctoral dissertation on town nursing, because there are still some town nurses, not in neighborhood health stations, but acting independently for municipalities, acting as the nurse for the whole community. So I really wanted to understand what they were doing and see if we could replicate it here. So those folks have staffed our flu clinics, they've, staffed our health education project, so we're I think they're an integral part. Why would you not take advantage of their skill set? I mean, they know where the people are who fall, they know where the people are who go to the emergency room.
How would that work out in Central Falls where there's no volunteers, the nurse one's only making it, right?
Actually, they work very well with us.
Yeah.
They're our best friends, and we have meetings like
They
every
do
week.
all
So we actually
They
have
come to the
access-
multidisciplinary team, they reach out to people who are high users of transport services, and they actually help keep people in their what do you typically do? And she said, well, I used to do a little bit of teaching. I run a walking program for the students. I have the kids with the tummy aches and the headaches and the, bruised knees come. I've had an occasional child with diabetes or a couple of kids who need their inhaler. And then she walked over to her locked medicine cabinet and she opened it and she said, now I treat anxiety. I have 8-year-olds on anti-anxiety. So everyone is feeling the pinch of, the sort of pressures. Maybe we're overdiagnosing. And on the other hand, I said to the student, really, if I was 8 years old, I'd be anxious too. Make me practice getting under my desk in case a shooter comes. Make me practice. They need it to be. They won't look the same. There'll be some aspects clearly that are the same. They won't be exact.
So let me ask this then, is there, let's say my community now is in Johnston and something elsewhere, Warwick and things like that, what would be the first step in initiating the conversation about potentially starting a health station within said community, not just Central Falls and Situate, but Johnston, Warwick, and the list
And
goes on.
we've certainly been, there have been individuals and small groups of people who have, contacted us and said, how'd you do that? How are you getting that? How come you guys have that and we don't have that? What would we need to do? So I think you have to think about who should be the core team. So there's going to have to be somebody with a little bit of political, legislative, sort of will somewhere in the community. I think that you probably have to have somebody with enough medical background that they understand, where health is and where it comes from. And then we sort of start this grassroots thing of who wants to hear about this, who wants to, take it on. We definitely need a healthcare partner, you know, a healthcare professional partner, someone who really can offer the individual primary care stuff, and it could be behavioral health, it could be dental, it could be medical, I mean, it doesn't really, it could be a nurse. I mean, a pharmacist, a psychiatrist, you know, sort of whoever, but someone who can bring that piece to it. Yeah.
I just have two questions. One is, how does the mayor of the city of Warwick work? Just as an example.
So talk about the mayor of City of Warwick, yeah, go ahead.
Well, it doesn't matter if it's Warwick or Grace or whatever. How does he get informed about the issues you were talking about, unique to the city of Warwick, like let's say the airport or air quality? How does the doctor with an office on Warwick Avenue inform the mayor of Warwick about it?
No, see, that's the challenge.
Yeah, that's what I'm
Yeah,
asking.
they are two separate things. Rhode Island is the only state in the union that doesn't have county-level health departments. We have a single health department in Portland who, and so what
Is that
central,
the size?
That is mostly the size.
but other
And
states have
Massachusetts-
counties. They
No,
have,
Massachusetts doesn't even have counties.
but they have, what do they have?
They have towns.
Town.
And, you know, essentially that's, you know, your municipalities are the only, because they, and
Michael went in and said, I think we could make a health station here. And that's how he sort of got it. It's gonna be, it is good that it happens to be this really.
Yeah, no, I mean,
and-
when you think about trying to spread it.
Yeah, yeah, they're so lucky in Central Florida. This mayor has totally adopted this.
Oh my
and
God.
is
Our mayor-
allocating resources and hiring people and spending money. I didn't want to miss it, because your name's been up.
I'm just curious, like, after so many years of doing meetings and reflections and sort of stuff, what are the issues on like the state and municipal law level in terms of, gosh, I wish somebody would pass a law or
In annoying places sometimes where they drop on my clothes and sometimes they fall out of clean. But if she wipes one with a betadine wipe and a sterile scissor and she snips it off, they pay her $120 for that too. So every time I go, I bring her a skin test as a gift. But how crazy is this? This is ridiculous. The whole, and everybody, I mean, really people understand that the system is so broken that to think we can take it and twist it a little and it will now work is a ridiculous way of thinking. And the energy and the time, there are 50 or 60 people that's outside the scope of the license that I carry and making assessments
But my
and
point
creating interventions, and I don't need a doctor to
If
tell me that.
Lifespan or Care New England doesn't like it, they could probably make life difficult.
How? What do they do?
Well, I don't know if they get powerful, what I'm thinking.
They have no authority over me.
No, I don't think they have authority over it, but I think they have influence in the state house.
The policy, legislation, regulatory sort of, you know, barriers and those kinds of things.
considering that
And
the legislature has passed 4 substantial bills the entire session, and they're about to end,
Yeah.
I would not count on getting legislation through about anything anymore.
I don't think we need to rely on legislation.
Yeah.
You as chair, you know, myself as vice chair, you know, I don't know if you want to be secretary or I would be secretary. She was just Kathy is secretary. It doesn't matter who we're secretary. Kathy is secretary. She's taking over.
He's gonna take over. What's your last name? What's your address?
174 Central.
Progress being very